Welcome to the next in the KDIGO Genetics and CKD Webinar Series. Today's episode is episode 8, the patient voice in genetic testing. My name is Bob and I'll be your moderator today. Note that today's webinar is being recorded. Thank you very much for the submission of the questions in the registration process. Our speakers will get to as many questions as they can at the end. Our speakers today are Judy Savige, University of Melbourne, Australia, and André Weinstock, Alport Syndrome Foundation in the United States. Without further ado, I'll turn things over to Judy to get us started. Go ahead.
So thank you, Bob. André and I have no relevant disclosures. However, we are both involved in patient support groups. André in the US and myself in Australia. So before we start, I just want to remind people that genetic causes are common in kidney disease and in kidney failure. And remember that there doesn't have to be a family history of disease. Sometimes there's only one person in a family who has a genetic kidney disease. The diagnosis can be made clinically or on biopsy or on imaging, but the most accurate means of making a diagnosis of genetic kidney disease is with genetic testing. And genetic testing also tells us a lot more than simply that there is a pathogenic variant in a certain gene. And we'll talk a little bit about that later. However, the availability of genetic testing is very variable in different countries and depends on the funding of the healthcare system and what is acceptable culturally also. Thank you. Over to André.
So that last point is to say, with apologies in advance, that there are really too many perspectives to take into account for a 1-hour session. So while Judy is most familiar with the Australian perspective and myself with the US perspective, and both of us being very deep in the Alport space, our apologies are that we'll be biased towards the Alport image from those countries. So we're going to try to do our best to expand to those other conditions when we can, and hopefully if there are any additional questions from that, they can be reflected at the end. So with that, I'll start into the beginning of the presentation. So when KDIGO invited me to present, of course, was honored, but also a little bemused because anything that I say is going to be the patient perspective. As we can see here in the photo, I'm an Alport syndrome patient and spent the bulk of my early 20s on a hemodialysis machine and during my undergraduate studies. This is typical of Alport syndrome for X-linked males in their early 20s to have kidney failure. But another thing I wanted to point out that is common for my misdiagnosis is that I had already been diagnosed with persistent proteinuria and hematuria at the age of 2 and had been wearing hearing aids from the age of 10. But it wasn't until I was 16 years old that I was officially diagnosed with Alport syndrome. So there was a period of over 10 years where we didn't have a diagnosis. And also this being in the early 90s, long before there was a simple genetic tool available to us. So what I really want to sort of get into is that, this is something that we may actually be taking for granted. And another thing that I think makes a nice story is that coincidentally to when I was on dialysis, I would go across the street after my dialysis sessions and was working in the undergraduate in the research lab of Dr. Cardi Raper doing genetics on fungus. And so I would take these large X-ray screens with me back over to the dialysis clinic and be looking for where the gene would change from the E. coli vector into a brand new undiscovered gene of this wood rotting fungus. And it would be a huge breakthrough if we could find 100 base pairs in just one day. So now that we have the availability to look for millions of base pairs for less than $1,000 in less than 24 hours is kind of miraculous. And something that we don't want to abuse, but also something that we shouldn't really just take for granted, and the power of that tool that we can use for diagnosis. So I want to start with a story of a misdiagnosis journey similar to my own in some ways. So in this case study, we have a 3-year-old girl in 2014 diagnosed with hematuria and proteinuria. The father has a low eGFR, about 50, but considering high blood pressure, everything else otherwise healthy. No history of kidney disease in 4 siblings or the extended family, nor the mom. At the time, the parents are recommend to start on an ACE inhibitor, but they decide it's premature. Go 3 years later, and the hematuria proteinuria is still persistent, a slight decline in the eGFR, and they, at this point, do start an ACE inhibitor. And also, it is prescribed to do a kidney biopsy. The kidney biopsy appears to be what's called IgM nephropathy. The nephrologist recommends that you should start a routine or a treatment of prednisone to see if that helps ameliorate the effects, but the parents decline because they are savvy enough to realize that there are many negative side effects to prednisone treatment, and they would rather keep their 6-year-old daughter off of that. However, a few months later, coincidentally, or it appears coincidentally, the daughter fails a school hearing test and fails it again after it's thought, oh, maybe it's just a fluke. That leads to a visit to an ENT who suggests, oh, maybe the hearing loss is a side effect of the lisinopril, and maybe we should take her off lisinopril. The parents, meantime, are doing some of their own research, and they think, hey, if we have a hearing impairment and we have this kind of kidney disease, maybe it's Alport syndrome, and maybe we should do a genetic test. But the nephrologist does not entertain that, and again recommends that they start steroids. So they, at that time, I believe, did start steroids. And what happened is that in a follow-up to make sure that there were no effects from the steroids, such as cataract buildup in the eye. An ophthalmologist recognizes 2 things that are very common in Alport syndrome. First, lens lenticonus, and also a little bit of flat retinopathy. So upon the ophthalmologist's recommendation, they get genetic testing, and that confirms a diagnosis of autosomal recessive Alport syndrome. The genetic counselor then refers the family to a new nephrologist at their request, and also introduces them to a link to the Alport Syndrome Foundation and our community. So the primary thing I really wanted to show with this is that a lot of physicians, nephrologists typically think of Alport syndrome as being a young white male disease. And this patient, in fact, from permission from her and her family, is actually a young woman of color, and not usually what you think of the face of Alport syndrome, but something that we, the patient community, are trying to say that Alport syndrome can be in either gender, and it can affect all sorts of ages, not just young white male. So fortunately, the patient is doing well, all things considered. And the mother, in conversation with her, she's relieved to have a diagnosis, but wary and anxious about her daughter's future. And the first thing I want to talk about is wary, because having been through this journey with her daughter and not having found a diagnosis, she's not sure when is the other shoe going to drop, when is it going to change again. And anxious, just want to put that as a placeholder for future reference later in the slide deck. So both my own patient journey and the patient just described kind of makes a point, which Dr. August Beer made over 100 years ago, that a smart mother makes often a better diagnosis than a poor doctor. And I don't want to pick on doctors. My own mom, who went through this very stressful diagnosis journey for over 10 years, is also a doctor. However, for us all to be a little more cognizant about listening to patients, especially engaged patients, when they request something such as genetic testing, not to be dismissive of it. And I don't think that's going to be a concern for the audience of this particular KDIGO presentation, but something for all of us to take out and broadcast to the larger nephrology and, in fact, the entire larger physician community. So one of the things that we've seen, and it's typically discussed, is that the cost of doing genetic screening is getting cheaper and cheaper and more readily available, at least in the resource first world populations that have the resources to do such things. However, this is, we see very often tied with another thing which is not given much credence, which is the internet. For better or worse, that patients who are engaged with their conditions and finding it now have all the knowledge of all medical things at their fingertips to understand, is the condition they have maybe a genetic condition, which used to be just the province of doctors. So if you consider that engaged patients are already doing their own research and are sort of self-selected, if you have a patient who doesn't really care about their health, they're not going to be asking for additional tests. They're not going to be pushing their doctor to do anything. That the primary point I wanted to make for this presentation is patients who request genetic testing should be empowered, not dismissed. And I would encapsulate everything that I'm going to say, and that sums up into this one point of, again, if a patient comes to you as a nephrologist or any kind of healthcare provider requesting genetic testing, there really isn't any excuse to not provide that to them. And even today, we are still getting patients coming into the Alport Syndrome Foundation community with these three common stories, or I'm going to call them myths, which they get from their nephrologists, which they have to struggle with. The first is, insert whatever your rare disease here is very rare, so it's highly unlikely you're going to, that's going to be the cause of your condition. Therefore, why even bother? The second is there's nothing that can be done about it anyway, so why bother? And finally, the third, specifically for X-linked diseases like Fabry or Alport syndrome, women are quote unquote only carriers. So what I want to take for the rest of my portion of the presentation here is to go one by one through these three myths and give us, the audience here, the data to deconstruct these, to basically dispel these so that we can better empower patients who are asking for genetic information. But before I do that, I want to make one very important caveat that before any genetic testing is done, it should be done with the resources of a qualified genetic counseling service in place. Just as we wouldn't prescribe an MRI and ask the patient to be interpreting their own MRI results, we do not want to do a genetic test and have the patient have to be interpreting their own genetic test. Having a trained, qualified genetic counselor is key as a part of step of genetic diagnosis. So let's take a look at that first myth, which is that insert whatever rare genetic disease, it's so rare, it's not likely that you're going to be having it. So there's a version of Occam's razor, which is often said, like when you hear hoofbeats behind you, don't expect to see a zebra. Well, if you do a little bit of research, you'll see that the person who is most commonly said with that is Theodore E. Woodward, who was a 1948 Nobel laureate for his work in typhus. I believe it was in 1948 he was awarded the Nobel. But if you do a little more digging, you'll see that what Theodore E. Woodward actually said was, when you hear hoofbeats behind you in Central Park, New York City, don't expect to see a zebra. So that little bit of context gets lost. And it's very critical because let's say if you happen to be in the middle of the Serengeti and you hear hoofbeats behind you, absolutely you're going to expect to see a zebra. So what we want to do is when a patient asks for this, you want to take it in holistically for genetic testing. Is there family history that shows other tendencies of that? Is it a pediatric patient who might behave differently when they're in the doctor's office versus what the parent says they're doing at night when they're not there? Or maybe you see disparate organs that are being affected that wouldn't make otherwise sense. And that is where, in the case patient that I had said there, that the ENT and the ophthalmologist were giving inputs, which then could be fed into the nephrologist. As a small aside, there actually was a time at the beginning of the early 20th century where zebras were kept in the New York Central Park Zoo. So even Dr. Woodward's statement needs extra context to say there could be zebras behind you for a very specific point in time. And one of the things we're seeing, and this is a slide that has been presented before in the KDIGO series with the work from Ali Gharavi at Columbia University and a paper by Emily Grootman and colleagues that came out in the New England Journal of Medicine in 2019. And they screened approximately 3,000 self-diagnosed or believed diagnosed kidney patients, all sorts of general kidney conditions with whole exome sequencing. They found about 10% actually had a genetic cause of it. And of that 10%, the number that had the call for a 3, 4, and 5 genes that were the underlying cause of Alport syndrome were almost as common as the PKD1 and 2, which cause polycystic kidney disease. However, on the right, in the B, the clinical diagnostic spectrum, the PKD1 and PKD2 were almost always correctly diagnosed as congenital diseases. But with the Col4A 3, 4, and 5 Alport syndrome were almost always incorrectly diagnosed as Alport syndrome. Furthermore, if I quote my esteemed colleague who's presenting here, looking at a meta study population and doing deep dives into registries such as the UK Radar Databank, in 2022, just this January, published a paper where they said X-linked is really probably as prevalent as 1 in 2,000 in the general population. If you do a Google search on how prevalent X-linked is, you'll get a number anywhere from 1 in 5,000 to 1 in 10,000 in general. So this is almost an order of magnitude less. And more importantly, and more interestingly, autosomal dominant version of Alport syndrome is considered 1 in 100. And this almost gets down to the root definition of what does it actually mean to have Alport syndrome. And when you consider the way autosomal dominant might be shown in the general population, it's almost more like getting a genetic diagnosis of APOL1. It doesn't mean you have a monogenic, typical Mendelian disease, but it's more like getting a diagnosis of a factor in a polygenic disease, which is a risk, indication of a type of risk that you would actually have. So not a full diagnosis that you're going to have kidney failure, but something to be notified to the physician that to watch your diet, be careful on your blood pressure, other things that you would generally want to do to avoid anything that would lead to potential poor kidney health. Going on to the second myth, which is, oh, there's nothing you can do about it anyway. We know that the standard of care for Alport syndrome specifically is to put the patient as soon as possible onto the highest tolerable dose of an ACE or an ARB. Research coming out of Göttingen, Germany from Oliver Gross and the Early Protect Project has now provided almost 25 years of data that shows the earlier you can get a patient onto ramipril or another ACE or ARB, the longer it actually prevents their kidney failure from happening. And this is actually extremely personal for me because I have a nephew. When he was born, genetic diagnosis showed that he had the X-linked mutation that I have. So by the time he was 1, he was already taking an infant formula ACE. With the hope that that gives my sister and the rest of my family is that it probably will be an extra few years, maybe even decades before his kidneys fail. From when mine failed at age 22, for his age, maybe it will be 30, 40, or even longer. Also, it's not just what drugs you can be put on now, but the ability to help research in future clinical trials and future research efforts to better understand the condition. While not a very robust pipeline, at this point, we have 3 active clinical trials in the Alport space. And enrollment in these is actually dependent upon an official diagnosis. And typically for the age this would, especially if it's a de novo mutation, a genetic diagnosis is going to be the only way you would actually be able to know that you're eligible for these types of studies in order to impact and capture to see does the drug work prior to kidney failure. Also, we're in talks with the Neptune Nephrotics Study Network. And what we want to find out from that is if you have Alport syndrome, we can link your genetic diagnosis to the information in the biosamples, the kidney biopsy, the blood samples, hair samples that could be collected and stored with this. That has also been cross-compared with not just the genetic type, but also things like the audiogram. Finally, another thing that we want to look further into the future is the potential for not just ameliorative therapies, but curative therapies. Research coming out of Washington University in St. Louis, led by Kohei Omachi, just published this past month. And this is from Jeff Miner's lab, has shown that you can selectively cure, quote unquote, a mouse with a nonsense stop codon type of mutation. And that this drug basically forces you to read through and essentially cures the Alport mouse as long as it has that type of nonsense mutation. In fact, very exciting to announce is that Elox Pharmaceuticals is now proceeding to a human clinical trial, phase 2, using this exact type of mechanism. Then further afield, there's the possibility of watching what CRISPR will do. Can we actually bring CRISPR into solid organs? And not just for Alport syndrome, but for all genetic diseases. This is a potential maybe 20, 30 years from now, we'll actually have curative techniques, not just for nonsense mutations, but all mutation types. Finally, the most pervasive and maybe insidious of these three myths for X-linked disease is women are, quote unquote, only carriers. Instead of me going into the details, again, I'm going to quote my esteemed colleague here, Judy, and just read out this, that for women with X-linked syndrome, highlighted, quote, 15 to 30% develop full renal failure by 60 years of age. That's about how many women with diabetes develop full renal failure at that rate. And when was the last time you heard a woman with diabetes say, oh, you only have diabetes? So this is a big challenge for us to try to bust this myth that women with X-linked Alport syndrome, women with X-linked Fabry actually have their own variant of the disease, which needs to be considered, treated, monitored for all those exact reasons. Furthermore, if you're a woman with an X-linked condition, you also have the additional anxiety that is caused by what does this mean for family planning? What are the effects of guilt, however misplaced, that you have for passing this on to your children? And these aren't just hypothetical beyond your own health as a woman with an X-linked condition, but we have statistical data showing that anxiety is really the biggest side effect of having, in this case, Alport syndrome, just from the unknown of what that does. And it circles back to what we had that original mother in the original case showing that that was her feeling, that she is mostly anxious for her own daughter's future. And what does that entail? So this is, to wrap up for the women are only carrier myths, is that genetic testing is even, in a sense, more essential for those patients because it's not just a hypothetical. The impact and the ability to treat them and to give them the resources they need is very critical. Finally, I want to take a big step away and kind of turn the tables on this before I hand over Judy, and that is I'm giving the perspective of a white male US-based Alport syndrome patient. But even to give a perspective of a white male US-based polycystic kidney disease patient can be completely different in its impact and perspective on the importance of genetic testing. So in this case of a about 30-year-old man who is at high risk of polycystic kidney disease, has a sister who's tested positive, has a brother who has tested negative. The mother absolutely knows that she has polycystic kidney disease, underwent kidney transplant, and is now 6 years post-transplant doing well. So the mother has never had a genetic test, but with polycystic kidney disease, you really don't need a genetic test once you see the cyst in the kidney. It's very relatively easy to understand that it's there. But what about the son? Does he want to get a test to say to sort of determine what's in his future? Well, the first thing is that he's seen his mother really struggle with tolvaptan. And he knows that if he had to take tolvaptan, he really wouldn't put up with it. So it almost in a sense like, as the title of the swear, where ignorance is bliss, just follow to be wise. But more importantly, this is a US-based patient. And this patient is just getting off in his career and knows that if he got genetic testing, which proved he had polycystic kidney disease, and let's say he's in a state which does not have Medicaid expansion, it's an unnecessary risk. He may lose his employment. He could lose his health insurance if that became common knowledge, or if the legislation were to be rolled back on quote unquote Obamacare. So I think this serves as a very good case to sort of say that what I presented earlier in this slide of saying that all patients should be trained, it's just those patients who wish to be tested are the ones who should be given the polytest. But we shouldn't be enforcing that on any patients who do not wish to be tested. And with that, I'm going to hand over to Judy for the remainder of the slides. Thank you.
Thank you, André. So I'm a clinician. I work in genetics, the genetics of mainly Alport syndrome, but I think we are referred patients with all kinds of diseases that may be genetic. And I did start out working on polycystic kidney disease. So these are the perspectives of what a doctor thinks that patients want, having spoken to a lot of patients and having been a patient myself. With other conditions. So what do we think patients want? They want to know the name of their disease, and we know that knowing the name is very powerful and gives people control. The doctors also want to know the name of the disease because it makes them also feel able to provide more specific advice and care for their patient. I think also it's reasonable to think that now that there's some discussion about the naming of these diseases, it's important for patients to be able to pronounce the disease name and to remember it, so not having a name that's too complicated. And this is particularly true because most people in the world don't speak English as their first language. We think it's useful for patients to know their genetic mutation, and often this will enable them to access specific treatments. People also want to minimise the harm to their children and grandchildren, and they want to help other people who have the same disease. I've also seen patients being very powerful, though, in focusing doctors and researchers' specific aims with undertaking research and saying just delaying kidney failure is important to us. It's not just about finding a cure, but having fewer years on dialysis. Patients also want to contribute to the development of expert guidelines, saying something is not acceptable to them, or could we make it more acceptable before doctors produce guidelines. But patients also want to receive help and support from other patients because they know that that can help to normalise their disease. And I think belonging to a patient support organisation is often very helpful for patients for all kinds of reasons. Patients do want access to the latest treatments, or to know about them at least and make a decision on whether they want to be involved. And they want their disease to be promoted and people to be made aware of it. They also want people to know of the risks of the disease. And they want to know about what future research is happening and that clinical trials are being enrolled appropriately. So I'm going to be using photographs through this presentation, and they're taken from the Alport meeting, patient support meeting that was combined with a researchers meeting in Siena a couple of years ago. And I've got a couple of questions that I wanted to address. So what are patients' expectations and concerns about genetic testing, including the risks and benefits? So I've gone over some of the expectations of genetic testing more generally in what patients want, that patients want an accurate diagnosis. They would prefer to avoid multiple diagnostic tests with all of the clinic visits and time that's involved. They may not know that they want to know the mode of inheritance of their disease, but that will tell us who else in the family is at risk of being affected. And they'll want to know what other clinical features they might develop from genetic testing. For example, if a mutation in that gene is usually associated with hearing loss or heart abnormalities. We can also tell from genetic testing what the clinical course of a disease is likely to be right. This is not just true in Alport syndrome, but in many different genetic diseases. The diagnosis may also indicate effective treatments and unhelpful treatments, and genetic testing can help ensure that affected family members aren't used as kidney donors. Genetic testing may inform reproductive planning, so telling us whether a man is likely to have a son who's affected or a daughter who's affected. But genetic testing can also help explain disease development for us and help experts to write guidelines too. So the benefits of genetic testing for a patient is that it can facilitate enrolment of clinical trial of a new treatment that may require a positive genetic diagnosis. Genetic testing will also unify people with the same disease so that they can support each other in patient groups. And the information is also useful even where the disease can't be confirmed genetically, because we get more information about the clinical manifestations of a disease from the group where we do have genetic test results, and that can be extrapolated to other groups too. What about the risks of genetic testing? André's spoken a little bit about this. I've put anxiety as the #1 point here, anxiety about the outcome, because genetic testing results are generally considered to be certain. But there's also other risks of genetic testing. Genetic testing may not be available to everyone. It might be too expensive. It may not even be considered in some environments. Genetic testing results is not always conclusive. Sometimes we have what's called a variant of uncertain significance, where we're unable to make a conclusive diagnosis. In some jurisdictions, treatment, even dialysis or transplantation, is not available. There are implications for employment and life insurance, and for medical insurance in some countries too. Family members who haven't even been tested may find out that they have the disease too, indirectly, as a result of knowing who in the family is affected. Parents may feel guilty about passing the disease on to a child, and we often see this. The children often have a very different point of view, though, talking about how wonderful their mother has been and how this was not something that she did deliberately. Then there's something also where people in a family who are not affected feel guilty and think, why wasn't I affected? I've always looked after my little sister and now she has this disease. There are ways of going about reducing those risks of testing, the mitigation strategies, and as genetic testing becomes more widespread, these strategies will be used more and more. So in terms of the anxiety about the outcome, genetic counselling is important here. Discussion about what the outcomes might be and preparing for the different outcomes, understanding that it is often better to know a diagnosis and to start treatment, and that treatment might be just much more rigorous control of blood pressure where there isn't something that's more specific. So how and should results be conveyed? I've talked about the preparation for learning that this is a genetic disease. Patients will have to provide informed consent to testing also. Informed consent means that the individual knows about the risks and benefits of genetic testing, and often the consent form will also include information and consent for submitting that variant to a variant database or a mutation database, and that information is used then throughout the world to assess variants in this disease too. So it helps improve the accuracy of the results that are available to other people with the condition. In terms of the result, it's important that clear language is used in the results, and that the disease name is spelt out, and the disease name should be accurate, informative and short. And the reason I've included that point is, as I mentioned before, the naming of these diseases is undergoing a re-evaluation at the moment with the intention of making these names clearer and more accurate and understandable both for clinicians and for patients. I think it's important that the patient is provided with a written or electronic copy of their genetic test result that includes a simplified explanation, because then the patient can take that copy to any doctor whom they go and see, and they can also circulate it to their family members too, who may be seeking their own genetic testing. I've mentioned already that there's this issue of a VUS, a variant of uncertain significance, and these are variants that can't be definitely explained as pathogenic or likely pathogenic. In some jurisdictions, VUSs can be followed up automatically at regular intervals by a laboratory and reassessed. So, for example, where I work, a VUS is funded to be reevaluated twice more at 18-month intervals. And so if a person who's suspected to have, for example, Alport syndrome, but the only variant that is found is a VUS, in 18 months' time, that person's clinician can contact the lab and say, could you please reevaluate this and tell me if you can now say that this is pathogenic or not. In many jurisdictions, a VUS is included in the results, and we have asked that VUSs and the strategy to follow them up is written in the result, so that patients are aware and can remind their doctor too. It isn't necessary that it's followed up at 18-month intervals. It might be followed up after 5 years because there might be more information then. So I think it's also important that patients have access to their electronic medical record and can see 3 years down the track how they're travelling too, and being copied into the correspondence and the results, which is happening more and more widely, I think, internationally. And certainly some patient support groups that run disease registries have patients submit their own data, register themselves and submit their own data to those disease registries. And the disease registries are used not only for recruitment to new treatments, but can also be analysed to find out more of the disease itself. So what does a genetic report look like? The results are pretty standardised. We tend to use guidelines that have been produced internationally. Most reports now say pathogenic variant rather than mutation. So it might just be that if you're reading a report and you think, well, I thought I had a mutation here, but I don't see the word used at all. The gene name is given in capital letters, and you can just Google it to find out what it is. There's a reference sequence which is accepted internationally, and your variant will be described according to that sequence. The decision will be that the variant is pathogenic or likely pathogenic. Benign and likely benign variants are not included in the report. And we use very rigorous criteria for pathogenicity, and they're being refined the whole time. So the variant might actually be something like given as P, then brackets GLY 624 ASP. This is just showing the amino acid substitution, and this is the commonest variant found in European people with Alport syndrome. There might also be some references, so some medical publications that describe a little bit more about this variant. And I've explained about variants of uncertain significance where there's not enough evidence to say that this variant is pathogenic. In general, if the lab thinks there isn't enough evidence, but this variant is likely to be benign, then it will not include it in the report. And it's useful to talk to a genetic counsellor in follow-up also to find out who else in the family is affected, and they may, the genetic counsellor would explain that process to you. So what are the social implications, ethical issues, cost concerns, etc. for genetic testing? These obviously differ in different countries with different medical systems. There's very few economic analyses have been undertaken. But when we made the argument in Australia for genetic testing, it costs about $1,500 Australian dollars that's provided to the lab for genetic testing and analysis in this country. And so that's a cost for the taxpayer. In contrast, dialysis costs at least $80,000 a year, and so that a test that enables treatment that delays kidney failure by 5 years saves about $400,000. So that's back of the envelope calculation, but you can see it is very cost effective to do genetic testing, to make the diagnosis, in this case of Alport syndrome, early, and it saves the taxpayer a lot of money. So some of these treatments available are very inexpensive, for example, ACE inhibitors and the flozins. And it would be useful to have some more general economic analyses now that we have many more genes known causing kidney failure and the risks of kidney failure. There are some alternatives to genetic testing, and the more genetic testing we do, the more we are able to refine these alternative tests. So the tests that are available are the tests that we used to do: radiology, biopsy, laboratory test. They're not as effective, they're not as accurate as genetic testing, but we are improving our ability to diagnose these diseases, comparing them with genetic testing. And when genetic testing is critical for a diagnosis, there are some other ways of obtaining genetic testing without a cost. There are some international research laboratories who are willing to undertake DNA testing for genetic variants as part of their research, and there's several very large groups doing this. There's also some pharmaceutical companies who are providing free genetic testing because they are interested in working out what is the natural history of this disease. So there are some other strategies for genetic testing. And finally, what is the rationale for testing even if treatment's not available? So these are really, a lot of these benefits are the same as I've spoken about already for the advantages of genetic testing. So even if there's no treatment, we get an accurate diagnosis and we avoid multiple tests and save clinic visits and time. We identify the mode of inheritance. We might be able to predict other clinical features and so search for them. The mutation severity will suggest the clinical course. The diagnosis may indicate effective treatments and avoid unhelpful treatments. Some of these effective treatments are inexpensive, even if they're not specific. And we can ensure that affected family members are not used as kidney donors. And the results may inform reproductive planning, and we can understand more about the disease by looking at the mutations and the clinical features in the individuals. Thank you.
Thank you very much, Judy. And really a lot of excellent points in there that I wish I had thought of first, but that's exactly why we have experts like you. I want to add at the end here some thanks for especially some patients for their input, especially on conditions other than Alport syndrome, to understand their perspective. And finally, I'm going to leave us with a last slide. Hopefully folks can take a screenshot of it. One of the most important things once you receive a genetic diagnosis is the ability to find other patients out there to support you, understand that you're not alone. So I've, at least for the Alport Syndrome Foundation, we have our sister foundation, the Alport UK, Fabry disease in the United States, polycystic kidney disease in the United States, as well as nephrogenic diabetes insipidus, von Hippel-Lindau disease, and is a more general resource for a lot of the rarer diseases that are out there, Global Genes, as well as the National Organization of Rare Diseases. And for a lot of these, they're also aware of their counterparts in other countries if and when they exist. So with that, very much thank you. And thank you again, Judy. And now we look forward to questions.
Okay, thank you very much for those presentations. At this time, we'll move into our questions and answer period.
Great. So we have a first question that has come in, and says, thank you for this important topic. Early genetic diagnosis can be a burden for the families. However, it might allow early therapy. From a patient perspective, what are the action items for the nephrology community, KDIGO, to help families in this process? Oh, well, thank you. That's an excellent question. I would say there are two key strategies that Judy and I sort of hit on. The first is it's critical to ensure that qualified genetic counseling is available for the patient. That is what genetic counselors are there for, is to answer the questions in a proper fashion, to provide resources to the patients or the potential patients and help them on that journey and to lessen the burden, if you will. And I would see the second thing, which is important, if it exists, is to link to existing patient organizations. I had added a link at the end of the slide presentation of those foundations, such as the Alport Syndrome Foundation, Fabry disease. It has been extremely rewarding, at least in my perspective, to see when a newly diagnosed patient who thinks they are alone, or the family of a patient, find this community, how enlightening that is to understand that they're not alone, and to hear other stories, to understand this is what this patient did for this situation. The only challenge with that is that for very rare diseases, there are not as available for that, but that's where more of these umbrella organizations, like in the United States, the National Organization of Rare Diseases, where you sort of link together with other very rare diseases. And internationally, I think there's being more and more crosstalk internationally, at least from what I've seen from like the Alport Syndrome Foundation. We know that there are similar foundations within China, within France, within the UK, within Australia, and these do collaborate with each other. And when we find patients in smaller, less resource countries, which don't have their own association, we welcome them in as much as we can. And I believe that to be the same with most of these national organizations, that they have international thoughts or work to help patients in those other countries. And then another question we have in here is that with the evolution of approved therapeutics or clinical trials within the rare kidney disease space, has there been any type of initiative from advocacy organizations, e.g. NKF, NORD, to encourage screening? This is a great question, and it really depends on where you are in the world. Putting aside, let's say you're in a country that doesn't have the resources for genetic screening, there are some nations that basically have newborn screening as part of their nationalized healthcare system. But reading into this, we say the NKF and NORD, the national in there, I believe, stands for the United States. And being an American, there are no other countries. It's just us, right? That in the United States, it's tricky because, in a sense, we've got a fragmented healthcare system, to put it politically politely, and doing a screening which requires people in versus people asking to be tested are two different things. So I think what we're looking for is the advocacy groups, such as National Kidney Foundation, National Organization of Rare Diseases, not advocating for screening for everyone, but making screening affordable and available to anybody who wants it, including physicians who will think that they need to prescribe it, instead of just saying everyone has screening. And that is an ongoing challenge that I wish I had a simple answer for within the United States, that yes, your doctor can prescribe this type of genetic screening and it's going to cost you this much and it's going to cost by insurance. Getting an answer to that has been very tough as one side, because it varies in the United States from state to state. And it also varies on what kind of insurance you have and also what kind of hospital system is. But it's something that we are trying to get a little more unified on. And within the Alport Syndrome Foundation, one of the efforts we try to do is provide a cohesive, guide to getting genetic testing. So I think that's it's a challenge in the United States, and something that the NKF and the NORD are working towards, but it's not something that we're going to see a nice simplistic answer for in the short term.
So I've got a couple of questions here, André. And the first one is, who should undergo genetic testing? So really, in terms of people thinking they might have a genetic kidney disease, who is likely to have one of these diseases? I think the important thing to remember is that inherited or genetic kidney disease is very common. And some kinds of kidney disease are almost always genetic. For example, many cystic kidney diseases, nephrolithiasis, lots of diseases are likely to be genetic. There is an issue that I tried to bring up before, and that is to say that you don't have to have two members of a family with a disease to say that this is genetic. A lot of diseases only occur in one family member. And there's reasons for that. And in particular, it's the type of inheritance. But just having one person who has a disease and you haven't got an explanation for it, there's no easy explanation, we would now be thinking this could very well be genetic. A lot of genetic diseases have their onset at a young age. So somebody might be born with cystic changes in their kidney or develop a lot of protein in their urine at a very young age, 3 months old, 6 months, 12 years old, up to even the age of 40. And we would still be thinking this could very well be genetic. So diseases where we haven't got another explanation, I would also be thinking are genetic. And then finally, diseases where there's another clinical feature, which is a bit unusual. For example, hearing loss. If I had a 30-year-old who had a lot of protein in the urine and a hearing loss, I would be thinking that's probably genetic, or a cardiac abnormality, etc. So they're all factors, and really even just one of those 5 points would be enough to say, I think this person probably has a genetic kidney disease and we should be trying to work out what it is. And then how do I arrange genetic testing for myself or my family member or for my patient? Usually the genetic testing will have to be performed by a kidney specialist or a geneticist, and your family doctor would be referring you to one of these specialists, and it will be the kidney specialist or geneticist or a multidisciplinary team who will order the genetic test after some preliminary investigations. And of course, the patient will have to consent to the risks of the genetic testing. And in many jurisdictions, the genetic tests take a while to come back. I think from what André has said, it's probably only a few weeks in the United States, but in Australia, it might be up to 3 months because there's a lot of work done, not just with undertaking the exome sequencing, but also in the analysis. And then, of course, there's the follow-up where other family members might undergo testing too, although this might happen, years later. It depends on whether the family members are at a stage where they're ready to accept that diagnosis and how urgent the need for treatment is. Okay, so I think that they were the main questions that we had to answer. I just want to finally emphasize, where can patients access new treatments? New treatments are often available in clinical trials, so there will be no cost to the individual, and often as part of the ethics process, if a treatment is shown to be effective and a patient is given a placebo rather than the treatment at the end of the trial, they may have access to treatment with the effective medication too. So thank you. Thanks very much to everyone for taking part in the meeting today, and to André and the team at KDIGO.
Thank you, Judy, and thank you again, KDIGO, for organizing this and allowing us to host.
On behalf of our audience, I want to thank both Judy and André for their great presentations and handling of the questions. Note that today's webinar was supported by an unrestricted educational grant from Natera. At this time, we will end the webinar, and you may now disconnect.